Good morning, one and all. This is a extreme happiness for me to be the part of this IC, and this is the most common sort of the topic which everyone is interested to know. So, going to the next slide, the main goals of the corneal scleral injuries is to prevent further injuries to the eye before the surgery starts, to triaging the patient and taking care of the various other injuries which is associated in the multiple skeletal system injury might be there, and you need to expedite the operative evaluation, and anesthetic clearance is needed if at all you go for any anesthesia problem. So basically, we need to have to obtain the infection control protocol has to be meticulously followed. We have to administer the systemic antibiotics as well as tetanus prophylaxis if needed. Documentation of all medical records is meticulously to be done. The type of injury, mode of injury, time of injury, who brought the patient, how many any previous treatment before addressing to coming to us, and all these are of lot of medical legal importance, and it has to be recorded and meticulously, and has to be then there should be a comprehensive and honest discussion about the surgical outcome or the intervention whatever you are planning to the patient if he is beyond 18 years and along with the family members. So as you know, that then commonly the Birmingham eye trauma terminology has been well established classification of injury. So according to this, you come across the closed globe injury or open globe injury. Closed globe injury is an injury where this ocular tunics or the are not involved. So it can be only contusion or lamellar lacerations. Open globe again classified into globe rupture and laceration where the ocular tunics are ruptured. So laceration goes for penetrating injury with a single entry wound, and then perforating injury at the entry and exit wound, and intraocular foreign body retained in the wound or inside the eye. So once you classify the injury, then you have to grade the injury. Grade 1, grade 2, grade 3. Grade 1 limits the limbus. Grade 2 is a 5 millimeter beyond the limbus, and the grade 3 is beyond 5 millimeters into the sclera. So grade 2 and grade 3 has got lesser prognosis or bad prognosis than the grade 1. So once you get the grade and dunning, then you have to have a Oculostoma Society score. And according to this score, there are various points starting from visual acuity estimation to the type of or grade of trauma that the patient has sustained, and for each thing it has been assigned a number. Like if it is NPL, it is 60 points. So you have to add on these raw points. Like if suppose you get 60 NPL, no perception of light, and then you got a endophthalmitis or globe rupture, then 60 plus 23, it is minus 47. So what happens with this? The score comes to like this: 0 to 45, 45 to 60, and so on 90. So here, once the score is there, then you get a score of 1 to 5. 1 being the poorest prognosis, and 5 being the good prognosis. So this is the prognostic indicator for the patient and for their attenders. So the battery of investigations are there. X-ray, CT orbit has to be done as a matter of routine procedure. Ultrasonography is highly needed, and the investigation pertaining to the general anesthesia clearance has to also be obtained. So plain radiograph shows the intraocular or interorbital for radiopaque foreign body and also orbital fractures, and it is also a major medical legal documentation. Ultrasonography assesses the radiolucent and radioopaque foreign body along with the posterior segment abnormalities. Computer-aided CT also helps us and in open glove injury where there is no contact, and also safe in metallic foreign bodies and no contrast needed in these cases. However, the radiation exposure is the major disadvantage of this procedure. So preoperatively, before going for surgery, the assessment is very important. We need to pad and bandage the eye after applying the topical antibiotics. Excessive use of topical antibiotics should not be used in an open glove injury. So then coming to the surgery per se. So surgery per se starts with the holding of the needle and the needle with the needle holder. So ideal needle holding should be at the anterior junction of anterior 2/3 and posterior 1/3 position. And after this, what is the aim of the suturing? Suturing has to have a watertight wound closure, restoration of anatomical relationship, restoration of the optic by visual function, and also prevention of future complications like secondary glaucoma or endophthalmitis. So this is the major way of doing it for suturing in the cornea. So Rose-Hayes technique of suturing has to be done because it is maintains the prolate shape of the cornea, in which the smaller sutures are put at the center visual axis area where the cornea is made a little bit flatter, and the peripheral long sutures will make the cornea stiffer so that the cornea maintains its normal shape of prolate. Next is the visual axis involving lacerations. This are again we have to use a no touch technique or minimal handling, and tissues visual axis should be spared. So if at all possible, you need to go for a finer sutures. So this is a video. You can see the video. This is a child with the injury of the steel scale, and with a anterior subluxation cataract. So in this case, what I am doing is that once it is the side port, I need to stain the lens. Because it is I didn't remove it as such with the whole capsule bag. Usually sometimes we tend to remove it whole capsular bag, then vitreous will come, then you have to do vitrectomy. I didn't do all this. I done a minor modification for that. I just ruptured the anterior capsule after staining it, and then I hydrated the lens, which is always like glue, so it comes out. Once you remove the this thing, I just left it like that, so that remnants of the lens, anterior lens capsule and posterior lens capsule can be used for secondary IOL fixation. So coming to the next, the two limbs of the, if you get a triangular shape injury, you have to consider the two limbs of the triangle as separate linear lines and sutures like this. So if you get a zigzag lacerations like that, you have to have the following anatomical landmarks, which helps to maintain its integrity and the prolate shape. So major landmark is limbus. Next is the pigment line in the cornea. So third is the sharp angles at the laceration edges, and the fourth is the stellate edges. So corneal scleral first we need to re-approximate at the limbus, and then scleral wound has to be sutured with nino, and corneal wound has to be sutured with tenolinon. So scleral suturing has been done as a technique of close as you go. That means you expose the the sclerocorneal junction and put suture starting on the limbus. This is one more case where you can see the uveal exposure and also the uveal prolapse. In this case, traumatic cataract is there and in an adult patient with devitalized cornea iris tissue. So in this case, it is presentation is more than 48 hours, you always go for the excision of the uveal tissue. If it is less than 48 hours without any wound infiltrate or any trauma injury to the this iris, and then you can always repose it back. Here we did it. Once you suture, and then you do a traumatic cataract. Always secondary IOL is better than primary IOL. You will avoid a lot of intraoperative complication. You do a SICS tunnel and deliver the nucleus. So next is the, as I told you, you have to suture as you go down. So once you put a suture at the limbus and the sclera, and then you repose this uveal tissue which is prolapsed back into the eye, and then you keep suturing it. So post-operative management goals mainly is to prevent infection and suppression of inflammation by using of steroid, control of IOP, and relieving of pain. So post-operative management can be given, starts with the oral and intravenous antibiotics, steroid and cyclopathy drops, and frequent examination of posterior segment is highly important in all cases of open glove injury, because they are predisposed to retinal detachment always. So traumatic, post-traumatic endophthalmitis, there is a publication which is well accepted. They say that a prophylactic intravitreal administration of antibiotic in high-risk cases is mandatory in a open glove injury. So who are the high-risk cases? Dirty wound, retained integral foreign body, delayed presentations, rural setting, breach of anterior capsule. These are all scenarios which cause the bridge early traumatic endophthalmitis. So this is the continuation of that. So when do you remove the sutures? You remove the sutures ideally at 3 months, or whenever they are loose before 3 months. Sequential number of tight sutures are removed first, and refractive corrections or spectacles or contact lens can be given after 1 month of suture removal. Follow-up is counseling is very important. Prevention of similar situation trauma has to be explained, and protection should be eye has to be done. Thank you for